Okay, welcome everyone, and good afternoon. My name is Maura Canavan, and I'm with the Community Health and Wellness Department at Suburban Hospital. Today, I'm so excited. We are joined by Dr. Brewer Gutierrez. Dr. Brewer is an expert in gastroesophageal reflux disease, and she'll be discussing that with us today. We will have time for questions at the end, but please, if they come up as you're listening, please put them in the Q&A box. And then after the webinar, you'll receive a link for an evaluation. So please give us some feedback so we can continue to improve our programs. This webinar is being recorded and will be sent out in the coming days so you can watch it back if you forget anything. Thank you all for being here, and I will now pass it on to Dr. Brewer.
Hi, everyone. Good afternoon. Maura, thank you for having me here. I am thrilled to be here today to talk to you about this fascinating and common condition called gastroesophageal reflux disease, or how we call it very frequently, GERD. Over the next 20 to 30 minutes, more or less, I will be covering absolutely everything related to this disease. All right. So I have nothing to disclose. Let's start by defining what is GERD. Acid reflux, overall, is when the acid content from its normal part of our stomach backs up into the esophagus. The esophagus is this long tube that carries the food from your mouth into your stomach. Occasional reflux is totally normal, and this can happen in every individual, children, infants, adults. Usually, when it happens on a regular, or we call it normal, it's after a heavy meal. Very important that you remember this picture. So again, we eat this is the pharynx or larynx, vocal cords, airway. The esophagus is this long tube, okay, that finishes in the stomach. This junction between the esophagus and the stomach is called lower esophageal sphincter. It's a muscular ring that usually is closed. When the food is coming down, when we are actively swallowing, involuntarily swallowing, the esophagus generates some contractions or motility that will actually make the food travel along the esophagus and into your stomach. When the food is going down, it is normal to have that ring of muscle relaxing, so the food can pass. After the food passes, that sphincter or ring closes to prevent then the backup of that content or the acid into the esophagus. I want you also to look and visualize this little line here. This is a muscle, and it's called the diaphragm. It's the most important muscle for the respiration in humans, and it separates what is the chest from the abdomen. The normal junction between the esophagus and the stomach has to happen at or below the diaphragm, and you will know why this is important. So going back, what is the definition of GERD? It's when acid reflux causes bothersome symptoms or damages the normal esophageal lining, okay? Damage to the esophageal lining or the esophagus, it's more likely to occur when this acid food and mixture refluxes frequently. The stomach content is more or very acidic than what usually is, and this happens when there's an imbalance between things that protect us and things that actually harm us. Or when the esophagus is unable to clear away this acid that we produce quickly. And this can happen when there are problems on the way our esophagus moves. We call this esophageal dysmotility. GERD is a very common condition. It affects approximately 44% of the US adult population on a monthly basis, and nearly 20% of the US adult population on a weekly basis. But for you to really, or for us, doctors, to really say, oh, definitely you have chronic reflux or you have GERD, the bothersome definition usually is more than 3 times per week. Obviously, anything above that is pathologic. Anything below that could be considered normal. What are the risk factors for GERD? So a hiatal hernia. You may have heard this multiple times and you are, what is a hiatal hernia? So it is a condition, and I'm putting this picture, and this is where I want you to remember the line, the diaphragm, okay, that muscle. So the hiatal hernia is a condition in which part of the upper stomach pushes up the diaphragm, through the diaphragm into the chest, okay? So the junction or that sphincter or muscle ring, instead of being below the diaphragm, is above the diaphragm. So by definition, having a hiatal hernia is one of the most frequent and important risk factors for GERD because your anatomy is already disrupted. Your sphincter, by definition, is not gonna work. Other risk factors, very important: obesity. People who are obese or even overweight have increased risk of GERD and also a hiatal hernia, because this is all related to increased intra-abdominal pressure into that area: diaphragm, lower esophageal sphincter, stomach area. Pregnancy, again, as the pregnancy advances, more pressure into the intra-abdominal area. Lifestyle factors and medications, very important. Some foods, fatty foods, chocolate, peppermint are the typical known things that can actually relax that lower esophageal sphincter. Caffeine and alcohol, very important as well. Cigarette smoking. Cigarette is one of the most important offenders of any of the gastrointestinal lining. It decreases the secretion of mucus. It decreases the production of saliva. And all these are important to protect the lining and also to help clear the acid from your esophagus. Certain medications, usually calcium channel blockers, which are medications that are used for high blood pressure, or muscle relaxants. Anything that relaxes the muscle can increase a little bit the relaxation of that sphincter and make a risk factor for GERD. Let's talk about the symptoms now. Also very important concept. There are typical reflux symptoms, and these are typical, common, okay? Heartburn is one of the most common symptoms of GERD. It is a burning sensation in the center of your chest that sometimes you can feel it actually in the throat. The other most common symptom is called regurgitation. It's when the stomach content and acid flows back into your throat and mouth. You actually feel liquid coming back up. So these two are the most common presentation. However, you have other symptoms, and I want you to remember this as well. We call this atypical, because not typical, and extra esophageal, because they are not happening within the esophagus. These are pain in the top of your belly or your upper stomach. It's not in your chest, it's a little bit lower. Chest pain that it's not feeling like burning sensation, like pressure, even discomfort, dual ache in the chest. Difficulty swallowing, very important. It's not the typical reflux symptom, but when there is a lot of acid in your esophagus and it's part of the complications of chronic reflux, you can start having like narrowing, damages of the lining and narrowing. We call that strictures. So that can cause difficulty swallowing. Laryngitis or changes in your voice or hoarseness. This is because the acid is actually getting into your throat and it can inflame your vocal cords and cause changes in your voice. Persistent sore throat or cough. Again, coughing because some content from the stomach can actually go into your lungs and trigger the coughing reflux. Reflex, sorry. Then this is also, not everybody knows this, but feeling a sensation of a lump in your throat can be like an indirect symptom of reflux. We, on the medical term, we call this a globus sensation. So it can be related to reflux. When do we want to seek help to our PCP, your doctor? Usually when you have difficulty or pain in swallowing, because that means something else is going on. There is a complication from chronic reflux. Feeling of choking. Again, can be related to a difficulty swallowing. If things go to the wrong pipe, you can actually start coughing or feeling that you cannot swallow or that you are choking. Having no appetite or unintentional weight loss. This is actually not a typical or atypical reflux symptom. This could be a sign of a complication. Chest pain. Signs of bleeding in the GI tract or gastrointestinal tract. You can see blood in your vomit, or you can see dark color like coffee ground material in your vomit, or black tarry stools. These are signs of GI or gastrointestinal bleeding. Again, laryngitis, hoarseness, changes in your voice. This should not happen. And very important, if you experience any new abdominal pain in the top of your belly after 60 years of age, when you never had this before, it is recommended that you see your PCP or your gastroenterologist. So regarding the diagnosis, there's no gold standard in the diagnosis of GERD. What this means is like we need a combination of different things to actually get to the diagnosis, sometimes even more than one testing. So some people think that the diagnosis of GERD is very, very, very easy to make. Let me tell you, sometimes it is not. So the diagnosis is based on a combination of symptom presentation, typical, atypical, a combination, endoscopic assessment of the esophageal lining. When I say endoscopic evaluation, is that your doctor, your gastroenterologist will put down a camera with light that will examine your upper gastrointestinal tract. We call this EGD, esophagogastroduodenoscopy. These are the gastroscopy. These are all common names you may have heard before. Reflux monitoring, and I am going to talk about this a little bit later, but there are dedicated tests to actually measure how much acid is coming into your esophagus. And this is one of the most important diagnostic testing. Response to therapeutic intervention. I will also talk to you about this. There are certain group of patients that you give one of the most frequent acid reducers and their symptoms improve. You actually could say this most likely is related to reflux, but this is not applicable to everybody. It's not generalizable, and we have to be careful about that too. It is important to rule out life-threatening conditions that can cause similar symptoms to those of GERD, like heart disease. It is not uncommon to have heart attacks that mimic indigestion or heartburn or chest discomfort. This could be actually a heart attack. So if you have never experienced this, I actually recommend you to go to the urgent care if you newly start experiencing this. Okay, so when we do the diagnosis based on symptoms only, and this is what I was telling you before, those patients only who have typical reflux symptoms could be a candidate of this trial of 8 weeks of the proton pump inhibitors or PPI, which are one of the most prescribed medications in the world. So if you give these to certain patients, young patient or less than 60 years of age who have had this, but now it's becoming bothersome, and you give a trial of a standard dose, 20 milligrams once a day of any of the PPIs, and the symptoms actually improve and consistently improve, you could say that, well, maybe this patient does have GERD. If symptom, like I said, then additional testing. When are you going to order additional testing? When there is no improvement in symptoms after this 8-week of what we call PPI trial, when there are no typical reflux symptoms. As I said, you will only do this on typical reflux symptoms. When there are symptoms that might indicate that there are other conditions such as red flags, difficulty swallowing, loss of appetite, weight loss that it's unintentional, risk factors for GERD complications, and we're going to talk about this later, but the word Barrett's esophagus is a very also well-known condition that happens with long-term or chronic GERD, and it's basically the changing of the normal lining of the esophagus for a lining that accepts or can live under acid, and typically is a lining similar to the gastric or the stomach lining. So this condition is actually a precancerous condition. So we really, we call it a complication of chronic GERD. So risk factors for this condition are many, but the basic ones are having chronic GERD, more than 50 years of age, actually family history of esophageal cancer or Barrett's esophagus, being a male, smoking, obesity. So these are things that we have to think about as a doctor when patients come to us consulting for reflux symptoms. So if my patient has some of these risk factors, I won't do a PPI trial. I will definitely start by doing testing. So let's talk about the actual test. So the first test we typically will do is what I told you before, the upper endoscopy. It's a flexible tube, camera that allows to directly examine, assess the upper GI tract. The upper GI tract involves the esophagus, like I showed you in the first picture, the stomach, and a little bit of the small bowel. We call that duodenum. So in severe reflux, you can actually have complications, like we said, and you can see inflammation, esophagitis, strictures, like I said before, or actually Barrett's esophagus. In these pictures, just for you to see how it looks, this is duodenum, okay, and it looks like furry, like villi, okay. This is a normal lining. The second picture is actually a big angle of the entire stomach seen from the junction between the esophagus and the stomach. And then this is what it is, the junction between the esophagus and the stomach. You see this line, we call that the Z line, and above this line, this whitish more lining is the normal esophageal lining, and the pinkish or salmon color mucosa or lining is from that stomach. So this is a very nice normal gastroesophageal junction. We can also take samples of all these areas, and we call that biopsies. And we do this routinely. People sometimes get scared when we say biopsies. We typically, even if it looks normal for GERD even, we take samples of the esophagus, the stomach, to make sure you don't have other conditions that can cause similar symptoms to GERD. Let's talk a little bit about the ambulatory reflux monitoring. So it's the most direct way to measure and confirm objectively the presence of acid reflux. The test will involve either inserting a very thin catheter with multiple sensors throughout your nose, down the esophagus, and placed into the stomach. And this catheter will stay there for 24 hours. Or placing a wireless capsule or sensor that will actually attach to the lining of your esophagus that your doctor will place during the upper endoscopy. And these tests can last 48 to 96 hours. Actually, more and more, we're only doing 96 hours because we want to capture the more data we capture, the better we can serve you later on. These sensors or the sensor will measure how often the stomach acid reaches the esophagus and how long does it stay in the esophagus. The patient will be asked to keep a diary of symptoms, and also the monitors will have some buttons that you will press when you have symptoms, when you're eating, when you're laying back, which are going to tell us if there is correlation of the symptoms with the actual reflux episode. Patient doesn't have any possibility to know when that this is happening. So, but sometimes there is correlation, or it can actually tell us if the reflux is well controlled. If we already have evidence, like we did an endoscopy and the patient has esophagitis or Barrett's esophagus, we don't need to do routinely a reflux monitoring because we already know that the patient has reflux, has complications of reflux. But there are some patients that, despite putting them on proper therapy, they continue to say, oh, my symptoms are not well controlled. In that case, we can also use this type of reflux monitoring while on medications, for example, to see if the reflux is well controlled or not. This is an example of the wireless sensor. We call it a Bravo pH monitoring device. Very common to call it Bravo, if you have heard it before. So this is the delivery system. This clear capsule is the actual sensor. This is the actual monitor, and you see it has like a little bed, a fork and a knife, and 3 different buttons. So this is pressed when the patient is going to lay, when the patient back, when the patient is going to eat, if the patient has heartburn, chest pain, regurgitation. And this is how it actually looks once placed in your esophagus. This, on the other hand, is the catheter-based one, obviously less popular because you have a catheter in your nose and you can only have it for 24 hours, but the concept is similar. This one, for the doctor, we can choose this one in patients who have atypical symptoms mostly, patients who don't have heartburn, regurgitation. Why? Because it's hard to correlate that your symptoms are actually related to reflux if we don't have a testing that will confirm that. And the other advantage of this less popular approach is that it can detect also known acid or weakly acid reflux. The Bravo can only measure acid. So as you can see, there are different options, and each option will be depending on your symptom presentation. Other tests that are very important in the reflux world, the esophageal manometry. This involves having another tube placed down your nose, esophagus, and lays in the stomach. And this will actually measure the pressure of that ring called lower esophageal sphincter in how your esophagus moves. In this test, we will ask you to actually swallow sips of water. And as I said, when you swallow, generates waves and contractions, and then that lower ring relaxes to have the food pass into the esophagus, into the stomach, sorry. So we actually want you to swallow during this test. By itself, it's not the first or a diagnose, it cannot diagnose GERD by itself, but it's a very important test that can give us information regarding your reflux and the future. How can we treat you, or what are the factors that are contributing to your condition? There is no specific esophageal dysmotility disorder associated with GERD, but there are some that are very typical in patients with reflux symptoms. A weak lower sphincter, ring, and something called ineffective esophageal motility, meaning your esophagus is weak all the way. It's very common in severe reflux. the high-resolution esophageal manometry, which is this test that we're talking about, is also required to place that little catheter that I showed you before, the 24-hour pH impedance. You cannot put that test without doing the manometry. The reason is because the manometry actually will tell us exactly where that sphincter is. And then the other catheter will be placed above that, like 6 centimeters above that. And it has a very important role in the preoperative, before surgery, evaluation before anti-reflux interventions. And if obviously once you are diagnosed with GERD, formally, your doctor tells, yes, you have GERD, your doctor gives you treatment and you are not responding to that treatment, we call that refractory GERD. A manometry is one of the first next steps in a patient with refractory GERD. This is how the manometry will look. We call it Manoscan. This is one of the most frequent available systems in most practices. There are others. So this is a beautiful mix of colors. This band here on the top is the upper esophageal sphincter. This lower band is the lower, the ring, the important ring. And this wave is the actual contractility of your esophagus. This is a totally normal picture. And when you swallow, you generate these, and this part, which is the sphincter, needs to open up, and you can see it. Here is the sphincter, opens up when you swallow, and then will close back again. So this is a very normal picture of a high-resolution manometer. Other tests that we also can order, something called a barium esophagram. This is a test that entails drinking barium contrast, and the technician will take a bunch of x-rays, and actually sometimes like a movie that will show the physician, the provider, how all that contrast goes down, and would tell us a lot of information about the anatomy as well. Should not be used as a stand-only test as a diagnosis for the diagnosis of GERD. But it's very important in complementing the size and the assessment of a hiatal hernia. So this test is going to be most likely ordered in patients who are going to get some sort of anti-reflux intervention. So what are the complications of GERD? I already kind of gave you an idea, but I'm going to mention in more detail right now. So erosive esophagitis, or inflammation, or ulcerations in your esophagus. And this is a actual picture of somebody with severe esophagitis. You have different grades. When it takes more than 50%, we call it grade C. And actually here you see more inflammation, C or 3 out of 4. So this is pretty severe esophagitis. You have esophageal stricture or narrowing. This is another very severe case of esophageal stricture. You can see a normal opening, and then you see like it's narrow or stricture. These folks can happen because of reflux, uncontrolled reflux. And this is the feared Barrett's esophagus. Right now you would see, well, it looks like the Z line. Yes. But this C line, like I show in the other normal picture, should be at the level of the junction or at the top of the stomach. Here, this lining is way up in the esophagus. So down here is the junction between the esophagus and the stomach, the anatomic ring, that the lower esophageal sphincter. So all this pinkish salmon color lining is not normal in the esophagus. But we have criteria for that. This can be a long segment, short segment, ultra short segment. But for your own information, the minimum you need to have this lining in your esophagus is 1 centimeter and up. If this color of this change is less than 1 centimeter, by definition, by guidelines, you cannot call that Barrett's esophagus. And the other important part of Barrett's esophagus is that you can see it, you can suspect it, you can say yes, most likely, but the main diagnosis is done by biopsies, taking actual samples of this tissue. Lung and throat problems. Like I said before, if the stomach acid backs up into your throat, it can cause inflammation of your vocal cords, it can cause sore throat, it can cause changes in your voice. The acid can also go into your lungs. It can cause pneumonia, asthma attacks, or asthma type of symptoms. Over time, this micro aspiration of acid into your lungs can lead to, a permanent lung damage. Fibrosis of your lung tissue. So it can be a complication of birth. And the other, dental problems, repeated episodes of, important severe reflux into your mouth can actually erode the enamel of teeth over time. So let's talk a little bit about management. Diet and lifestyle changes can help relieve GERD symptoms. And I want you guys to understand this because it's not trivial. It's really important. There are people with mild symptoms that can actually control their disease only by lifestyle changes, diet and lifestyle changes. There are other people that still need to do it, but it's not enough. And no matter what you do to treat your GERD, lifestyle changes and diet are part of the whole process. It's not that, oh, I got anti-reflux surgery, I'm going to do whatever I want. No, you guys need to understand that GERD is a chronic condition. You will say, Dr. Brewer, what are you saying? Yes, it is. Imagine like you're dealing with high blood pressure, diabetes. It is in the sense that not comparable, obviously, but it's like dealing with a chronic disease that doesn't have a miracle cure. You have often to do multiple things in order to control it. So regarding diet and lifestyle changes, weight loss in overweight or obese patients is critical. Remember, we said being obese or overweight puts pressure into the abdomen, can worsen or actually may appear a hiatal hernia, and obviously will worsen your reflux symptoms. Avoid meals within 2 to 3 hours of bedtime. So people who have GERD cannot have late snacks because that's one of the main things that will trigger the symptoms at night specifically. Avoid, obviously, tobacco products, smoking. We already said decreases saliva, increases the harm of the entire GI lining. Avoid the trigger foods. And this is something very important. This doesn't mean like you will never be able to eat chocolate, peppermint, no. What I tell to my patients, yes, you have the typical things, tomato sauce, citruses, spices, fatty foods, peppermint, but not every patient will have these foods or things will trigger their symptoms. So I always say, avoid your trigger foods. That's the most important part because what is triggered for me might not be for you. Elevate the head of the bed 6 to 8 inches, especially if your symptoms are mainly at night. I still recommend for anybody to elevate the head of your bed, no matter when your symptoms happen. There are wedges out there that you can buy. Very important, avoiding sleeping on the right side and actually sleeping on your left side is recommended. There is a paper that was published in the New England Journal of Medicine that actually compared prospectively, like and randomized control trial, right versus left, and there was like a decrease of reflux episode on the left side and increased on the right side. And this is a merely anatomic situation. Wearing loose, comfortable clothing, like very tight clothing, could again increase the intra-abdominal pressure and trigger reflux episodes. Now, let's talk about medication. So we have the typical, what we call antacids. Alginates are another type of over-the-counter medications we can use. Very common names, Tums, Maalox, Gaviscon. Here in the US, Gaviscon is different than Gaviscon Advanced that comes from the UK. The Gaviscon Advanced from the UK is what has the alginates. The Gaviscon from the US doesn't. We don't have in the US alginates in formulary medications. There are other ways to find it, and it's a great, great type of medication. So in general, these two types of medications neutralize the stomach acid, and they are only used for short-term relief of mainly heartburn. The effect overall will last about 30 to 60 minutes, no more. So these are not medications that are meant to actually heal anything. It mainly helps for symptom control and on a short term. The alginates will float. It's like an algae. It's like a mixture, like a slur that when mixed with food, it will be in the top of your stomach and will actually prevent that the new acid or the content flows back into it makes like a virtual barrier to prevent things to go back up into your esophagus. It does have a little bit more like prolonged effect, but still, it doesn't heal anything. The histamine receptor antagonist, or what we call H2 blockers. Very common names, famotidine or Pepcid, cimetidine, Tagamet, nisatidine. The former medication called Zantac was also an H2 blocker that was recalled. It doesn't exist anymore. So these medications overall reduce the production of acid in the stomach. They are more effective than antacids, obviously, on relieving heartburn, and the effect obviously will be also longer than 30 to 60 minutes. They are not usually effective in people with moderate to severe frequent symptoms. By the way, the antacids and this are to treat mild symptoms, okay? Now, people with moderate to severe symptoms need other strategy. With alginates, antacids, and H2 blockers, you are not going to control the disease. So for this type of symptoms, this is when the famous proton pump inhibitors play definitely a crucial role. So you have, we call them PPI. You have all these types, dexlansoprazole or Dexilan, esomeprazole Nexium, lansoprazole Prevacid, omeprazole Prilosec, pantoprazole Protonix, rabeprazole, Acifex. These are all part of the same family. They are much more effective than the H2 blockers to reducing the stomach acid. They usually your doctor will say, okay, take it for 8 weeks and then you stop. During 8 weeks, if there is esophagitis, if there is uncontrolled symptoms, usually all that is the time frame that things can heal. So if we say 8 weeks is for a reason. Not some people say, oh, I took it for 3 days and it didn't help. That is not enough. You need to give time for the mucosa or the lining to heal. If symptoms after 8 weeks of stopping the medication, the symptoms come back, or if there is evidence of severe esophagitis or Barrett's esophagus, then you will need to take these medications long term. If your symptoms actually return after 3 months or more after treatment, but there is no esophagitis, you actually can be recommended to do another course of 8 weeks and stop and see, okay? In long-term treatment, the goal is to keep the patient on the lowest possible dose of a PPI that can control the symptom and that patient can tolerate. And this is to prevent long-term complications. So, I wanted to understand that, as I said, with GERD is a chronic disease. With mild symptoms, you might be able to control it with lifestyle changes and H2 blockers now and then, or actually PPI as needed. Like I said, you do 8 weeks, you do great, and then after 3 months, in a year, you have symptoms again, you can do this again. And that's a perfectly reasonable approach. But people who we already know have Barrett's esophagus, they have erosive esophagitis, they have a stricture. These patients cannot be off medications. So if you plan to keep these medications forever, which is it's an approach, obviously the patients need to understand long-term side effects, etc. But otherwise, you have to look for another approach to the disease. But those patients will need to have something, either medications, surgery, or endoscopic approaches, okay? So overall, this is a statement, even our guidelines, we use this as, like when we talk to our patients. So they are safe. There is a lot of propaganda out there, but they are safe. However, they are expensive, and especially if you need to take them over a very long period of time. The long-term risk of these medications that are proven based on randomized trials, etc., there has been proven cause effect of these medications is gut infections. One of them very typical is the Clostridium difficile or C. diff. It's a bad diarrhea that can happen. It's a bad bacteria that will colonize your microbiome, and it's treated with antibiotics. And you can have recurrent of this infection. Technically, it increases a little bit the risk of other type of infections because your acid is less acid, and it's a culture for bacteria. And then it can reduce the absorption actually of minerals and nutrients like calcium, vitamin D. So some people can actually develop osteoporosis. There is a lot of things out there. Dementia, that has not been proven. And I want you all to be reassured about that, because that's the main question or concern that people come to my clinic and say, I don't want to be on these medications because they can cause me dementia. That has not been proven. This is one of the most prescribed medications in the world. So it obviously, if you look back and see people who got dementia, oh, they all take PPI. That doesn't mean that the PPI is the cause of that dementia. Kidney disease, though, it also has been named, and yes, PPIs can cause something called interstitial nephritis. It's not that common, but people who have already some degree of kidney disease, obviously we want to avoid giving these medications, especially long term, okay? This is a new medication in the market for moderate to severe symptoms and actually erosive esophagitis. It was approved by the FDA late 2023, potassium competitive acid blockers, or PCABs. The only one available in the US since December actually is called vonoprazan. And it's a new class of medication. Apparently, it's being said based on studies in Japan, in Asia, that is the most effective medications to reduce the stomach acid, and was approved for us in December, and they have been available in Asia for many, many years, more than 5 years. But gladly, we already have these here. So refractory symptoms, like I said, some people do not experience complete symptom resolution with PPIs. And this is actually, it can be seen in 40% of the population. And this is called refractory GERD, okay? So if you are in this group, the options will include splitting the dose of the PPI. Sometimes your primary care, your GI sends a dose. It is a good approach to take the same dose twice a day. These medications need to be taken 30 minutes before a meal because they need acid to get activated. And the most acid we have is 30 to 60 minutes before a meal because our stomach is preparing to all the acid to digest foods. So that's when you need to take it. Increase the PPI dose or switch into a different PPI. Believe it or not, that works. If you are, for example, in 20 milligrams of Prilosec or omeprazole, you can increase to 40. If you're in 40, you can actually go to 80 and splitting the dose, 40 in the morning, 40 at night. That's kind of the maximum dose we would ever give to the patient. Also, I've been 5 years in Nexium. Okay, let's try a different. Let's try Protonics. Let's try Prilosec. They all have similar strength, but there are some that are a little bit more strong than others. The strongest of all the PPIs is the one called dexlansoprazole or Dexa. And all the strength is compared to the mother molecule, which is the omeprazole. Switching from a PPI to a PCAB. Again, it's very new here, so it might take some time. We might need prior authorization. Some insurances still are not being very proactive on approving this. Adding other medication. You are on Prilosec or on omeprazole. Well, maybe you can add as an adjunctive, not to change. You can add an H2 blocker or famotidine, or you can add alginates and to try to control the symptoms. Further testing to confirm or refute the GERD diagnosis and or rule out other problems. So this goes back to patients who did a trial, did well, they have typical symptoms. Symptoms disappear. And then the patients start noticing that the symptoms are more frequent, more bothersome, and are not responding to PPI. If you have not done any workup for these patients, this is the time you will start to do all that. You will start to do the reflux monitoring, manometry, everything that we discussed before. Consider surgical treatment. And surgical treatment includes here anything that will restore or enhance or fix a potential hiatal hernia and the valve, the gastroesophageal junction, make it a little stronger to prevent things to come back up. And this can be done by surgery or actually endoscopy. Anti-reflux interventions overall. It's recommended as long as the patient has obviously a full workup saying, yes, your symptoms are related to reflux. There is a hiatal hernia. There are persistent troublesome symptoms despite the use of long-term PPI. And actually one indication is also the patient doesn't want to take these medications because they are concerned about long-term side effects. The best response of the anti-reflux intervention is those patients who have heartburn and regurgitation as their main symptom, who actually do respond to the PPI. These are excellent candidates for anti-reflux intervention. Critical to understand that people with refractory reflux have actually reflux-related symptoms in order to offer an anti-reflux intervention. Because if you didn't do any workup and you do an anti-reflux intervention and the patient doesn't improve, oops, we don't know what was going on beforehand. And overall, and this is not the norm, but if people have atypical or extraesophageal symptoms there and doesn't have any atypical heartburn or regurgitation, the chances of responding to any anti-reflux intervention are a little bit less than people with typical symptoms. Doesn't mean that it doesn't work. It can work, but again, we need to choose wisely the patient. So laparoscopic anti-reflux surgery. This might be like a whole world. It's just I'm mentioning this to you so you're aware that this exists. So the main gold standard surgery for reflux, it's called laparoscopic Nissen fundoplication. It's done by laparoscopy, like the name is, and basically you are wrapping the dome of the stomach around the end of the esophagus, where the junction between the esophagus and the stomach is, on a 360 degree fashion, okay? And this is how we look at the end. Again, it's creating like a valve and preventing things to come back up. The caveat and why it's not that popular, it's because there is increased risk of dysphagia. Dysphagia is difficult to swallow. Patients swallow and feel the food getting stuck in the throat or the chest. And also because it's tight, people are unable to relieve gas. So people get bloated, distended, because they cannot burp, they cannot vomit after this procedure. It's the most studied procedure ever, and it works. But these are the caveats. Laparoscopic partial fundoplication. The Nissen is a full 360. Then you have all kinds of iterations to make it partial, not make a full wrap. So you have one of the most typical ones is this one called the toupee. Toupee is, instead of 360 degree wrap, is 270 wrap. As you can see in the picture, it's a little bit more open. And it has shown that it can get same results, but data says that it could increase the risk of have recurrent GERD over time. DOR is another type, which is even less, it's like 180 degree wrap. So it's even less than the toupee, okay? Then you have this kind of new technology called minimally magnetic sphincter augmentation, or LINX. Maybe you have heard about this. That's why I want you to know it exists. It is a ring, titanium, and this ring is placed by laparoscopy. It's a full surgical procedure, and the surgeon will place it at the level of the junction between the esophagus and the stomach. It works very good in some patients, but it has side effects or complications. It's a little bit obviously less invasive than wrapping your stomach around the esophagus. There is risk of difficulty swallowing in more than 3/4 of the people right after the procedure. Patients can wake up for the surgery saying, I cannot swallow. But this is because the actual newness of the procedure of the ring in your body, and then starts to feel that this will, the edema, etc., the congestion will decrease, and the patients usually are able to swallow. But up to 11% of the patients can develop difficulty swallowing long term. Important information is that because it's metal, it's compatible or can be used in an MRI machine. If you know MRIs, you cannot use any metal. You could have an MRI with this technology. There is a small risk of what we call erosion into the esophagus, meaning the rings long-term with years can actually erode, break the lining from the outside, and an endoscopist can actually see the ring on the inside of the esophagus. And at some situations, we as endoscopists have needed to remove the ring from the inside because it completely or almost completely went inside the lumen of the esophagus. And this is very important because after patients get any sort of bariatric surgery, meaning to lose weight, very common sleeve gastrectomy, or even with a gastric bypass, but the sleeve gastrectomy increases the chances of reflux in 40 to 50%. So if patients did not have reflux before that surgery, they can develop it up to 50% of the chances after the surgery. So in this patient population where you don't have a normal anatomy anymore, LINX could be a good option. The most important part with LINX is that you have to have a perfect anatomy, no hiatal hernia. You cannot put this in a patient with a hiatal hernia. Roux-en-Y gastric bypass. This is an anti-reflux procedure as well in patients that are obese. Okay, so I want you to remember this option. But still, we don't typically understand why some patients can have reflux after this procedure. And finally, endoscopic therapies. There are many, many, many endoscopic therapies that are out there for the past 20 years. Some are not available because safety concerns over the years. And only two that I'm going to show you very quick are available. The Strata procedure, which is energy delivered to the ring, to the lower esophageal sphincter, and TIF, which is called transoral incisionless fundoplication, which is like a stapler, and we can actually create a nice valve from the inside, not like the surgeons from the outside. And these are the current two techniques approved by the FDA. This is the Strata, it's a catheter, it's a balloon, has some needles, and the idea is to inflate the balloon, and those needles get into the muscle of that ring, the lower sphincter, delivering energy, and that energy will make that muscle grow. And by growing, it will technically narrow that area. And the other one is the TIF, like I said. It is a stapler, it is completely done under endoscopic guidance, and you actually take the tissue from the esophagus and the stomach, and you put, like, we call it plications. You put some fasteners, which are like these little plastic sutures that you start making multiple of these, and you will have this nice round valve at the end of the procedure. But this is partial as well. It's not a full wrap like the nascent fundoplication. Again, a caveat is that it has to have a hernia less than 2 centimeters in order to work. And in 2017, the TIF was approved in combination to hernia repair. So now we offer in patients with more than 2 centimeter hernia, we combine with the surgeon, we repair the hernia, and the GI does the TIF. Take-home messages. GERD is a common disease that can happen when the stomach acid backs up into your esophagus, causing bothersome symptoms. There are typical and atypical reflux symptoms associated with the disease. The diagnosis is based on the combination of symptoms, trial of medications, and more than one testing. And management depends on the severity of symptoms and includes lifestyle changes, medications, endoscopic procedures, and surgery. Thank you very much.
Thank you so much, Dr. Brewer. That was fascinating. Really appreciate all of the information. We have about 2 to 3 minutes left, and we do have 2 questions. So our first question, did you say there was an age limit for PPIs?
Age limit, not really. There is not. And even babies can take PPIs.
Oh, great. So any age can take a PPI.
Any age can take
Great.
PPIs.
Okay, and then is burping a couple times after eating a big meal a symptom of GERD?
That's a great question. It's not a typical symptom of GERD, but definitely it can be seen. And when it's only once or twice, again, any of the symptoms that can be related to reflux need to happen more than 3 times a week to be considered bothersome and to be potentially a GERD. Because remember, occasional reflux is normal. Everybody can reflux. In burping multiple times, once every 2 months, it's not considered pathologic reflux.
Thank you. And did you say that the spiced pepper can be a trigger?
Yes, but the most important aspect is what I said. It's not what the theory, it's what triggers in you. But yes, the typical triggers that have been described all the time are citrusous foods, tomato sauce, chocolate, peppermint, alcohol, but fatty foods overall. And the reason is because those will relax that ring or sphincter.
Great, thank you. And our last question comes from a person that's been on a PPI for 20 years. And so with that, what is the risk for kidney disease?
So we don't specifically know when or how that will present, but sometimes when you go to your physicals, to your annual physical examination, and your doctor orders some comprehensive metabolic panel that will see how your creatinine is over time. We have seen that certain people who are at risk, not everybody will develop kidney disease, not everybody will get infections, not everybody will get osteoporosis, but there are certain individuals who we don't know why, that definitely the PPI can start to create a decline on this kidney function. But again, if you have been on PPI for 20 years, you should ask, do I really have reflux? have I evidence of reflux in any testing? Or why am I taking this medication for 20 years? What happens if I stop it? Oh, I cannot be without medication because immediately the symptoms will recur. Then definitely you would be a candidate to investigate why. Why do you need this medication for 20 years?
Great. Well, thank you so much, Dr. Brewer. It is 3:01, so I want to thank you all for your time, and to you, Dr. Brewer, for sharing your expertise. I hope you all have a great rest of your day, and I hope you'll join us to learn again soon.
Okay, bye-bye, everybody. Thank you very much.
Thank you.